Hello, I'm Karen Bean and I'm a health economist by trade. I work at Orchard Therapeutics. I've been an economist for the last 18 years with special focus on rare diseases. And this particular analysis has been done with a view to help understand a bit more about the disparity in treated and untreated patients treated with a drug called ARSA and why there is such a need for implementing newborn screening. So there's been a application to the RUSP, which is all the data and the framework underpinning it is completed, and it's under review as we speak. There's been a couple of meetings, preliminary meetings about it, and all going well, we'll find out in May of this year. Then obviously there are RUSP-aligned states, and they will have that 2-year or 18-month or 2-year window to implement if a positive recommendation. Well, no, this is the problem. So at the moment, the majority of cases are diagnosed symptomatically because it's a rare disease, but by the time you've gone through it, it can be presenting with some early subclinical symptomology, but it's not obviously linked to MLD. And unfortunately, by the time the diagnosis has occurred, the patients are beyond the window for treatment for the most part, and particularly for the most prevalent form, which is the late infantile form. There's just no treatment options. It's literally just best supportive care. So there's an unfortunate paradigm at the moment whereby you're in a situation where the eldest child is diagnosed symptomatically and can't receive any treatment, and then they'll genetically test the siblings who are still without any symptomology, and they can experience treatment. So you can imagine the difference in a family where you have one child like in that, bedridden, and one that's running around at home. So. Whenever you're doing trials and you're estimating treatment effect in a population, and you're obviously extrapolating that to what would happen in reality, there's always a level of uncertainty when you estimate the treatment effect, mostly because in genetic diseases there's a variability in the disease progression due to the different genotypes and also different environmental factors and way in different countries. So the beauty of this analysis is it's a sibling analysis, so children from the same household, so same genotype, same environmental factors. So some of that uncertainty or noise that you get around estimating treatment effect is negated because you have the same conditions. So you're really taking away some of that extraneous, well, I call it noise. What we did is we looked at the clinical trial population, and within that there was we identified the patients pre-treated symptomatically who had a sibling who is enrolled in the natural history comparators trial. And then we looked at two outcome measures of gross motor function. So one was the GMFC MLD, which is like a 7-level system where from independent walking, which is like level 0, up to level 6, which is complete loss of all voluntary movement. And then we looked at GMFM 88, which is another measure of motor function. And as the name sort of suggests, it's a 88 question sort of questionnaire split into 5 domains. And within that, as children age, it kind of curves up, as you can imagine, and by the sort of the age of around 5, they hit the total score, which is about 100%, and that's the natural one. And so for the siblings, what we needed to do, because we wanted to be, you had to be at the same age, so we looked at the age and where they were with these 2 outcome measures, and they had to be within 3 months of each other. So any of the sibling pairs, that you had to have an assessment within 3 months of each other's age, and actually when you look at the data, some of them are really tight. So you're literally looking at the same environment, same household, at the same age in the disease pathway. And then what we did is, if we look at the results for the GMFC MLD, I think it's extraordinary if I'm honest, but there was, I think it was about 86% of the treated siblings had a difference of at least 4 in the GMFC MLD level. I mean, and if you want to put that into context, it's 86% can still walk, like so level GMFC level 0 or 1, whereas 86% of their matched siblings were in GMFC level 6, so the complete loss of all voluntary movement. And so it's extraordinary results, and the same was replicated with the GMFM. I think from the top of my head, I think for all that there was slightly less sibling pairs within that analysis, but mostly because GMFM is just you can't look at the data retrospectively and the natural history cohort, so there just isn't as many data points. But that was, I think the difference overall for all the sibling pairs was about 76%, I think, and it was most pronounced in the late infantile MLD group, and I think that was around 84%, which is, given the total score is 0 to 100, there's a difference between the two treated and untreated groups of 84. So you can see there's so my main conclusion from it really is that there's such a stark difference in the motor outcomes between the treated and untreated siblings that, and obviously the treated siblings were only identified because of their older symptomatic sibling couldn't be treated. So it really, really reinforces the need for newborn screening so that all patients can receive timely intervention, not just these younger siblings of the older symptomatic ones. I think it's not isolated to MLD. I think the challenges that exist for all conditions, but particularly for MLD. The work is being done, and it's been done well. The assay specificity and sensitivity has been published, and the data is excellent. There's clearly an effective treatment option for it, and now it's just going to be a factor of undertaking the RUSP process and then seeing how we can reduce the barriers to implementation on a state-by-state level, really. And I think we've already started to look into that. Because I'm an economist, I've already started to model some of that aspects about what are the barriers, what are the costs looking like, how can we help to overcome some of that. I think there are some ideas. I think once you receive a positive RUSP recommendation, that's one of the challenges overcome, because the states have a certain time frame in which to implement the legislation in order to do so, and quite a lot of states take on that challenge. For the ones that don't, I think there's going to be some work within the community. I think that's the main thing, so bringing together the right stakeholders and the right people together, so policymakers, the clinicians, the patient advocates, to really show and highlight this evidence. I mean, that's the key thing. Let's looking at the evidence. It's so clear from that, and really trying to sort of not so much lobby, but just get the evidence out there, show and bring the people in that need to be in front of the right people to try and push this through quicker. I think for ALD, I think was recommended in 2016, and I think we've got 46 states, so it's about 80%, and that's 9 years ago. And then you've got MPS 2, which I think in the last 2 years there's 11 states. So that's why I was saying it's definitely not isolated to MLD. But I understand that you can't suddenly, I can give you another example, you can't suddenly implement screening if they're not ready for it. So they do have to be ready. So for example, I was talking to a newborn screening director in California, and they were saying that they had implemented something earlier, and then they weren't ready, and the infrastructure wasn't set up, and then they had to go back like 9 months over the preceding time and redo everything. And that's so timely and costly. So they need to be ready. The lab agreements, the computer software, the infrastructure does need to be in place, and that doesn't happen straight away. While we're waiting, for example, for screening, making sure that the diagnosis is what can we do to improve early signs and symptoms diagnosis, because surely that's got to be the first start. So maybe some more of that kind of information and dissemination of information.